for the organizing committee for putting this session on and for inviting this panel to be here. And thank you all for sticking around for I know it's been a long day, so thank you so much for sticking around for this last session. I'm really excited to have this panel. Slides, sure. We've got I think a great panel put together, and our keynote speaker, what we'll do is we'll start with our keynote speaker, who's going to talk about hepatic artery infusion pump chemotherapy for cholangiocarcinoma. And I'll introduce him in a moment. We will then have Dr. Raphael, who's one of my partners at the Odette Cancer Center in Sunnybrook, who is the medical oncology lead of our hepatic artery infusion pump chemotherapy program for colorectal cancer, give a little background about that. And then we will have a panel discussion. We're really privileged and delighted to have Dr. Soltys, who works in the Health Canada office, will join us to share a regulatory perspective. And really appreciative of Erik Bradstock, who's actually one of our colorectal hepatic artery infusion pump chemotherapy patients, who's here to share his perspective in terms of treatment with hepatic artery infusion pump chemotherapy, and then we'll have a full panel discussion. I think we'll start with the two talks, and then we'll invite the rest of the panel up. So I'm going to start by introducing the distinguished Dr. Rocha. I'm going to have trouble calling him distinguished without laughing because Dr. Rocha is one of my close colleagues. We trained together actually at Memorial Sloan Kettering probably about 15 years ago. I don't even think I want to read his bio. I'm just going to talk about him instead. So he's a wonderful surgeon and friend. He trained at Sloan Kettering and then went on to practice as an HPB surgeon in Seattle, and then more recently moved to Oregon, where he's now the division head of surgical oncology there, and also the physician in chief at the Knight Cancer Institute. Dr. Rocha is a prolific global traveler and speaker. He speaks Portuguese and Spanish, and so he's really has a huge presence in Latin America and probably spends more time south of the equator than north of the equator. He is the surgical representative on a number of leading trial committees and cooperative groups. It's really a great pleasure to have him here joining us. He's also, I think I was telling someone earlier, he's probably more Canadian than I am. So we can feel free. We don't have to hold back on any of the US jokes in front of Flavio because he's really more Canadian than he is American. So with that, Flavio, thanks for being here.
Well, thank you, Paul, for that the generous introduction. I'll admit to some of those things, maybe not all of them. I think the only other thing I would add is that Paul and I had a long-standing weekly basketball game in the streets of New York City. So we'll talk about that later at dinner. But I really like to thank Rebecca and Leonard and the whole C3 team for inviting me here. It's been really an amazing meeting. And thank you for sticking around. You know, I've been around the Cholangiocarcinoma Foundation in the U.S. for a long time. I'm happy to see friends who are here. And they really, just to give a sense of what the power of advocacy and foundations can do, really launched my career when I was a fellow in this disease, which back then really didn't have a lot of options. We really didn't have a lot of information. So it's been great as my career has developed to see all the achievements we've made. And of course, you know, there's miles to go before we go to sleep. So let's dive right in. So to my disclosures, I'm going to talk about the pump, but I have no financial ties with Intera. These are my slides. They did provide some pictures of the pump and a video of how it works just for educational purposes. And my other disclosure is that I do love Canada and I love Canadians and I have lots of friends here. And when I lived in Seattle, I would go to BC often. And I don't want to get too political, but anyway, I'm happy to be here. So, okay, so I'm just going to kind of go through some of these just because you probably have heard of this all day. But biliary tract cancer, interestingly, kind of can be a variable disease about whether you're in Asia or North America. Different risk factors, some that are perhaps not so increasing and others that perhaps are. including we think about sort of the metabolic syndrome, viral infections, cirrhosis in the US, and the fact that we think we might be seeing an increase in intrahepatic cholangiocarcinoma. But this may be due to two different things. One is the classification, because as we've learned more about the molecular profiles of cholangiocarcinoma, a lot of the sort of cancer of unknown primary that was kind of the bucket diagnosis has now been more refined at the cholangiocarcinoma. And at least in the US, in the AJCC staging system, it was lumped in with HCC for a long time, up until the 6th edition. So now they've been separated since then. So that's why we might be seeing this, this purported increase. So as a surgeon, I got to tell you about what do I think about, right? So I'm thinking about what are the principles of local therapy. So of course, I'm always trying to cure disease when it's amenable to resection. That's really every time I look at a film and see a patient, that's what I'm thinking. But of course, you know, that's not the case for everybody. So then I'm also thinking, well, if they're not resectable, is there a way for me or my colleagues to control the disease progression, right, and preserve the liver? Because a lot of times what gets folks in trouble is the liver failing, not necessarily the cancer spreading. And then, of course, when we can't do that, can we at least palliate the symptoms and provide some meaningful benefit when that disease is unresponsive to other treatments? So just to give you a sense of what the landscape is, this was it's a great series from Taro Endu. I just got a chance to catch up with him a few weeks ago in Miami. When he was at Memorial doing research, he looked at the Memorial Sloan Kettering database of intrahepatic cholangiocarcinomas. And what was the kind of, you know, the localized population, where did they wind up? So out of those patients that were 238 at the time, you can see here about less than half were actually explored for curative intent, meaning the majority were not resectable. And out of those, only 70% were actually underwent a potentially curative resection. So it turns out to be only about a third of patients that presented to that high volume center. And you can see some of the reasons why they were not unresectable, including multiple liver lesions, nodal metastases, locally advanced disease, or they were unfit. And so even those that were resected, right? So these are folks that we think we've actually cured with an operation. You can see that 62% had a recurrence rate at about 2 years. So again, surgery by itself is not the answer. Even in those that had solitary tumors with no positive lymph nodes, the recurrence rate was about 50%. But if you had multifocal disease or positive lymph nodes, that recurrence was almost universal if you did surgery alone. And the majority of those recurrences were actually in the liver. And so there was some mixed response, but usually if the disease came back, it came back in the liver. And the predictors were things like number of tumors, size of tumors, positive lymph nodes. But at the time, in 2008, we didn't really know much about molecular markers. So again, this is the state that we are now. So what are the local therapies? So I talked to you about resection, which is the main thing that I do. Of course, transplant is becoming more of an option. It's still, I would say, it's in the experimental setting for intrahepatic cholangiocarcinoma, but there are more and more centers, including ours, that have now opened programs. We heard a little bit about tumor ablation, and you know, the classic ones were radiofrequency, microwave. IRE is a modality that uses a high voltage current. And I did not add histotripsy here because that would take us a long time for us to discuss all the pros and cons of that. There's also the catheter-based hepatic artery-directed treatments. We heard a little bit about the Deltic trial, Y90, and then of course the focus of this talk will be about hepatic artery infusion, as well as the different radiation modalities, including protons. So this is a nice article, actually by two of our panelists, Dr. Raphael and Dr. Karanicolas. Kind of summarizes the different therapies you can do to the liver. Now, this article was written for colorectal liver metastases, but they also apply to cholangiocarcinoma. So you can see going from left to right, the local therapies versus the regional therapies versus the systemic therapies. And so hepatic artery infusion fits in the middle there, and you'll see the pump in the artery there, and we'll go over in a little more detail. So what's the rationale for the pump? Well, we learned a while back that while the liver has a dual blood supply from both the hepatic artery and the portal vein, the liver tumors and metastases are actually only perfused by the artery. So they have a single blood supply. So that's the advantage number one. Advantage number two is that if you give the chemotherapy through the artery, the chemotherapy gets extracted in the liver and concentrated during first pass. And actually very little of it goes beyond the liver. So you really get a maximal dose to where the tumor is. We just went over the fact that the majority of metastases occur in the liver, and so it gives us an idea of what are the possible indications for a pump. including what we call destination therapy, which is for those patients that are unlikely to become surgical candidates. For those that maybe need to be converted from unresectable to resectable. And then, of course, the other scenario where we typically use pumps in the colorectal setting is after surgery. Do we put the pump in and then give the treatment to try to prevent recurrence, the so-called adjuvant setting? So this is a video, again, this is the video from Intera, just giving you a sense of what it looks like with the hepatic artery feeding the tumors. This is what the Intera 3000 pump is, which it's based off the old Codman design. You'll see the catheter there with a couple rings, and the rings are there to help us secure the catheter to the artery. You'll see it'll either be placed in the left lower quadrant or the right lower quadrant, gets placed in what's called the gastroduodenal artery and then secured. And then once the pump is then filled with drug, that drug then gets emptied and goes straight into the liver, and again, with the arterial delivery to the tumors, and the tumors ideally respond. So this is kind of what we use at OHSU as far as our indications and contraindications. Pretty standard stuff. I know that Sunnybrook may have a couple tweaks to this, but really they have to be fit, they have no kind of intrinsic liver disease. I think the big things is to look at the contraindication. So really any significant extrahepatic disease. And what I mean by that is, small lung nodules, we don't really concern ourselves too much about. Aberrant arterial anatomy is something that we have to be very careful about. So we get a dedicated, what we call an HAI CT scan, which is basically an angiogram to look at what the vessels look like, their size, their distribution, and so forth. The big thing for cholangio is patients that have biliary strictures or obstruction. So those we look very, very carefully, because one of the downsides of the pump therapy is the fact that it can injure the bile ducts that are also fed by the artery. And that's actually how we control the dosing. And then for us, at least, patients that have had previous radiation, including Y90, are not candidates for pump. Now, this is a relative contraindication. I have heard of centers that do not follow this. I'd be curious to hear from Paul and Michael later about their experience. The other challenge we have, at least in Oregon, which is happens to be a very rural state, is also the ability to come travel and get the fills. And I'll address that a little bit later in my talk. So what does the pump look like? So this is kind of a schematic of it. It's really not a very complicated design. It's a bellows system. So basically the needle goes in, it fills the chamber, the springs get loaded, and then basically it starts emptying as soon as the needle comes out. There's also a bolus port that you can use for different reasons. And so, but they both go through the same chamber. You can see what it looks like. And I love being in Canada because I can tell patients that it looks and feels like a hockey puck, right? So I think everybody can relate to that. I will not get into the Four Nations tournament, but, and you can see where it gets implanted there. So this is a nice article that kind of summarizes one of our colleagues, Mike Litsky, who's on at Duke, who's also got a very active pump program. You can see there all the little ties that get onto the artery, how the pump gets placed. And then in the operating room, you'll see that liver on panel A is not diseased. It's actually a healthy liver, but we put methylene blue dye in the pump to ensure that the whole liver is being painted with the perfusate. If you're doing it robotically, you can use ICG, which is that green tracer there. And then what we don't want to see when we do this in the operating room is panel D. So you see the arrow there is showing some blue on the stomach. So that's what we call extrahepatic perfusion. And so we don't want to see that, because that means that the chemotherapy is not going to go to the liver and it's going to go to the stomach or the pancreas and cause problems. So when we see this in the operating room, we have to go back. While we're there, we have to go and find whatever artery is supplying that area and tie that off. After that pump is placed, patients usually come into the hospital for a few days to recover. And then we also get a nuclear medicine scan to again confirm that there's no extrahepatic perfusion. So we do have these sort of checks and balances, or belt and suspenders, if you will. So you'll see there in panels F, G, and H, you'll see the nuc med scan. And we want to see, again, both lobes of the liver light up. And we don't want to see panel H, which is uptake in the head of the pancreas. So again, that to us means that there's extrahepatic perfusion. And so then we have to take that patient then to the IR suite, and you'll see panels I and J, where they found a aberrant artery that then had to get coiled, and then the subsequent nuc med scan shows no extrahepatic perfusion. So once that's done, patients get filled, they go home, and then they come and get seen by our medical oncology team and start their treatment. The panels on the right just show some of the potential complications, which typically have to do with pump pocket, infections or seromas. On occasion, you'll see, on the panel there on the right is a catheter eroding into the bowel. These are things that, are not often happen, but can happen. So this is just something to be aware of and why we're very diligent and careful about taking care of our pump patients. So we take significant ownership of them, if you will. The drug dosing, as I mentioned, FUDR is a drug that's mainly used, and it's basically the same as F5FU, but it's a prodrug. And you'll see there that it gets converted in the liver to about 100 to 400 times its actual dose. So that's why it's so effective. You can use other drugs, things like mitomycin, oxaliplatin was used in France. You get some concentration, but not nearly as much as FUDR. We tend to use the liver function tests as the measure of dosing, because again, I mentioned that the biliary toxicity is what prevents us from this continuing this therapy. And so again, this is the other reason why patients, when they come get a pump, they get all their chemotherapy with us. So our medical oncologists take over their systemic as well as their pump therapy. So how does this compare to other treatments? So my colleague, Dr. Schroff, had this actually very interesting study. This was the initial phase 2 study for the GAP regimen, which you might have heard previously. Very good waterfall plots for a response rate of 34% with gemcitabine, 60 patients, all biliary tract cancers, of which 12 actually were converted from unresectable to resectable. 9 of those were intrahepatic cholangiocarcinoma, so it kind of gave a sense of perhaps that might be the strategy for this drug going forward. She was able to then take this to a phase 3 trial. This is the SWOG 1815 trial that compared the GAP regimen versus GemCis, which was the standard at the time. Fantastic trial, accrued in record time. Interestingly, had the highest numerical survival in the literature, which is 14 months. But the control arm overperformed, and so the GemCis arm was 12.7, which is about 1.7 months higher than the ABC trial. So this turned out to be a negative trial. But just to give you a reference of what is the reference for advanced cholangiocarcinoma, is about 14 months, according to 1815. Interestingly, there were some subgroup analyses done, and this study has now been published in JCO, so that the gallbladder cancer subset, as well as the locally advanced subset, may have pushed the survival a little bit higher to 19 months versus 13.7. Now, these were exploratory endpoints, so you can't really bank too much on this except for perhaps hypothesis generating. Of course, the standard of care, as this audience is probably very familiar with, is TOPAZ-1. This is the triplet with the immunotherapy of durvalumab. Again, I'm not going to go into details in the trial, but just to give you a sense of the numbers. So, that survival is 12.8. So you'll see, again, you can't do cross-trial comparisons, but numerically different than the gemcitabine. But because the control arm underperformed the 1815, it is a positive trial, and so did the long-term outcome as well. Of course, interestingly, the Katie Kelly that published the Keynote trial right at the same time or shortly afterwards, very, very similar curves, very similar response rates, about 26%. So these are the two standards, at least in the US, GemCis Durva, GemCis Pembro. But again, keep in mind that survival rate. Okay, so now switching on to pump. So this is something that the group at Sloan Kettering had a longstanding interest, mainly due to Nancy Kemeny and her work in metastatic colorectal cancer. So this was one of the first trials that looked at giving pump therapy to primary liver cancers that were unresectable. It was 34 patients, of which 26 had intrahepatic cholangiocarcinoma and 8 had hepatocellular carcinoma. And you'll see in this trial that the disease-specific survival was quite enviable. Again, for an unresectable population, almost 30 months. So look back to the trials that I just presented to you of 12 months and 14 months. Interestingly, there was a little bit of a dichotomy between ICC and HCC. So you'll see in the cholangiocarcinoma cohort, there was almost a 54% partial response rate, 42% stable disease, and only 1 progression. Not as impressive with HCC. And so this is why this was kind of taken forward in the cholangiocarcinoma population at that time. So several other phase 2 trials were done. I don't have time to summarize all of them, except that this was a nice paper that put together their whole experience. So this is both prospective and retrospective, and then looked at the difference between patients that had liver-confined disease versus regional nodal disease, and whether patients got HAI with systemic therapy or systemic therapy alone. And again, there appeared to be an association of better survival with HAI and systemic therapy. And at least in this cohort, 8 patients were then converted to resection, and of course then begged the role of whether this could also be used for adjuvant therapy. More to come on that. This is then expanding the cohort outside of New York City. So this is now a bi-institutional study, Sloan Kettering and Washington University. Also a phase 2 trial, 42 patients, HAI and systemic therapy, the majority chemo naive. And you'll see here again the survival curve, 25 months. So again, better than what we're seeing with systemic therapy alone. Was not a randomized trial, but again, just comparing to the other historical controls. Very enviable 1-year survival of 90%. And interesting, the exploratory endpoint of IDH mutated tumors that appear to have a significantly better survival than the IDH wild types. But again, a small study, single arm, 2 institutions. Bas Korkamp, who is over at in the Netherlands and has his own pump program there, put then together this nice systematic review and meta-analysis looking at what was out there at the time between the Sloan Kettering studies and others. Again, mix of prospective trials and retrospective studies, but 154 patients that were pooled. And he was able to actually take that information and then compare it to what was the unresectable ICC population cohort in the ABC trials. Because remember, ABC trials were a mix of all different cholangios, locally advanced and metastatic. But really, the 3-year survival for this population was 36% in the pump group, and I would say almost 0 in the ABC trials. It was actually, if you actually look at the population, it's about 1 to 2%. But very specific, unresectable, non-metastatic intrahepatic cholangiocarcinoma. So the Sloan Kettering group continued to look at this further, and now really focusing on are there subgroups that may benefit from pump therapy, let's say over resection. So if you actually look at this study from Alice Way and Bill Jarnigan, in the node negative population, clearly you see that resection appears to have a better survival than HAI. But if you actually take the patient that had node positive disease, those curves are overlapping. So again, suggesting, not proving, suggesting that perhaps in the node positive population, pump may be equivalent to surgery for whatever reason. Is it biology? Is it the fact that the pump can control the liver disease? It's hard to know, but again, very kind of hypothesis generating. What they also saw is that perceived benefit in the IDH mutational status went away in the node positive patients. So again, is there something about the disease once it leaves the liver and goes into the lymph nodes that changes things? And they started to look at certain molecular signatures. And again, this is as the molecular age became more apparent, NGS became more available, they were able to identify this signature, what they called a high-risk signature, which was those patients that harbored KRAS, P53, and CDKN2A deletions, really no matter what you did, had a pretty poor outcome. And this goes back to then also the question of multifocality. So again, this is now a retrospective multi-center group from the US and Europe, and looking at number of lesions. So as you get from 2 to 3 to 4 lesions, it really appears that resection and hepatic artery pump may be equivalent. Again, retrospective study, but take it with a grain of thought. So this is the trial I was referring to. This is the Pump 2 trial that Dr. Korkamp presented at ASCO GI just last year. So this is looking at the HAI infusion chemo for unresectable intrahepatic cholangiocarcinoma. A single-arm study, but comparing to historical controls of systemic therapy. Very similar responses to what we got in New York. So 88% disease control at 6 months, 8% of patients getting converted to resection. And you can see there at the bottom which ones were resected, and not surprisingly, it's the ones that had the largest response from the HAI therapy. And of that, 1 patient actually had a complete pathologic response. When he then compared that HAI Pump 2 cohort to the historical controls, you can start seeing really here where the benefit may be. So the 1-year OS, the 2-year OS, the 3-year OS was superior in the pump arm. But again, you're comparing to historical controls. So there is now a randomized trial that's ongoing. So this is here through the, not through the NCTN, but through an RO1 mechanism. So 164 patients are getting randomized. The initial systemic component was actually GEM-OX because the Sloan Kettering group had significant experience with that. But this was designed before Topaz came out. So I know that they're changing this to GEM-CIS-DURVA at this point. But this hopefully will answer the question, which is what we really want is, does pump add benefit in addition to systemic therapy? Now, this is open at a handful of sites at this point. I know Bill is looking to add more, but hopefully if we can get this trial accrued and get the results, it'll give us a more definitive answer. So this is just for patients. Well, we have an HAI program. We have several group of surgeons and all sorts of team members that I'll go into in a second. But we readily make patients aware of this for both cholangiocarcinoma and metastatic colorectal cancer. It's in our website. We have links, hyperlinks that go to the different aspects of the program. And what does it take? Well, it really takes a village. So while we think the medical and the surgical oncologists are the key ingredients, which they are, there's also a whole host of other folks that we need. And I would tell you that our medical oncology social workers probably do the yeoman's work of screening patients for eligibility, looking at their cost projections, looking at travel difficulties. Certainly, as I illustrated earlier, the nuclear medicine, radiology, and IR teams really kind of make sure that the pump is working well. And then, of course, our outpatient infusion team and our nursing team have a huge role, and their training is critical for getting these patients through therapy. So as the pump became more, I don't want to say in vogue, but popular, because this is not new. Pump's been around since the 60s. We got more centers, right? So you'll see here, at least on the East Coast, they seem to be a little more concentrated. We have a handful on the West Coast. But this was a nice survey that was put out to the HCRN, which is the Hepatic Artery Research Consortium. I believe Dr. Karanicolas is on there as well. But sorry, we don't have the map of Canada on there. But we don't have Mexico either. That's just how we roll these days. But this is sort of the survey that went out to everybody. And it kind of said, what were the steps that were critical for their program? And so this is just a survey, so take it for what it is. But as you saw, certainly having the surgical expertise, the medical oncology expertise, but then the nursing came up as number 3, nuclear medicine, and so forth. And then as far as hurdles, you can see there what the biggest ones were, which I think you're experiencing as much as we are, which is regulatory was probably the biggest thing. And part of this had to do also with the fact that the original pump, the Codman pump, stopped production. So we had to switch over to a Medtronic pump. And in the US, we had to apply for IDEs through the FDA. And then once the Intera company brought back the Codman, then things became a little more streamlined. But the second most difficult thing was the device and equipment access. And then, of course, the drug access as well, which I know is challenging everywhere. So what about how did programs get started? So this was actually a nice paper, and our senior authors here in the audience, looking at programs that just started and it's really all these what I call memorial metastases. So the fellows that trained in New York and then went out there to the world, released into the wild. And you can see here what it took to actually get these programs up and running. But this just shows you that it is feasible. There's nothing special about the water in the East River that makes pumps work. And so this is the initial experience, at least, that came out of that group. Sky Mayo is the one that started our program in Oregon in 2016. And this was our initial experience. And this was mainly for metastatic colorectal cancer. And you can see there mostly unresectable patients, a handful of adjuvant patients. And you can see how we defined biliary toxicity a little different than Dr. Kemeny did. We were very, very stringent on the LFT parameters. And so we reported a biliary toxicity rate of 24%, which seems high. But again, only 3 patients actually required stenting, which was the sort of the gold standard definition of biliary toxicity. So what does our program look like now? So this slide is a little dated, but I did update the bottom. So this is this was June 2023, we had put in 59 pumps. And you can see the distribution as far as colorectal liver mets, how many were for unresectable, how many were adjuvant. And then, of course, what we're interested in today is the intrahepatic cholangiocarcinomas. And I'll go over the trial that Dr. Mayo had put together initially. We also put 5 pumps in off trial. And then in 2024, I just got kind of our year-end numbers. We did put in 15 pumps for metastatic colon cancer and 7 for cholangiocarcinoma. So you'll see the cholangiocarcinoma numbers are rising every year as, again, the data is becoming more available. Where do our patients come from? So the majority of our patients do come from the Northwest. So we serve, our catchment area includes Oregon, Idaho, Washington, and Alaska. And yes, I have put a pump in a patient from Alaska who comes down and flies down every 2 weeks to get the fill. It helps that I think he's a family member that works for Alaska Airlines. We also have put a pump in a patient from British Columbia. And so I'll talk a little bit about that maybe in the panel session. And we keep getting requests from Canadian patients in both British Columbia and Alberta. So one of the challenges we've had in the US, which may not be as much of an issue in Canada, is the insurance, different insurance providers and different carriers. So we were able to get patients with Providence Insurance, Kaiser, and Moda. And then more importantly, we were really interested in trials. So I'll go over the Helix 1 and Helix 2 trials a little more in detail. There's also a national trial that's undergoing accrual now for colorectal liver mets. And then Dr. Mayo is planning also an HAI trial, putting oxaliplatin in the pump to minimize any peripheral neuropathy. So this is the Helix 1 trial. This was a trial that was a labor of love to get everything through because it actually accrued during the pandemic. So as you can imagine, having troubles recruiting trials and then having people travel during a global pandemic is very challenging. And this was based on a little bit of an outdated regimen. So the induction chemotherapy regimen was FOLFIRINOX because this trial had started before Amoebica had read out. So it was induction FOLFIRINOX systemic, then pump, and then adjuvant FOLFIRI. It was a single-arm open-label study. And the primary endpoint was really to look at toxicity and feasibility of this approach. 9 patients were screened, 4 ended up being excluded, and 5 was actually the goal that we wanted to just kind of get this preliminary data. So we did complete the trial, and you can see there on the right the treatment course and how long patients were treated and what their disease status is. The other interesting thing about this trial is that we got a lot of correlative endpoints. So we really looked at both radiomic endpoints, serum collection, tissue collection. We also had a medical anthropologist who was a PhD in nursing who looked at distress levels in patients and other patient-related outcomes about getting their pump filled and traveling and anxieties over scan results and so forth. So that manuscript is still under writing for us to get that information, but I think very important to get. So we've now, with the new standard, are about to open up a second follow-up trial to this. This is the Helix 2, now looking at the standard of care induction regimen of gemcitabine or valimab. Again, getting then the 21-day cycles, and then getting the pump in, and then continuing in the adjuvant setting. And lots of correlative endpoints with blood collection, quality of life, and even now we have somebody who's interested in microbiome, so getting fecal swab collections as well. Kind of in parallel, we've been looking at sort of how to modify dosing for pumps. And so Isaac Schwantes, who's one of our research residents, did this study looking at a modified dosing schedule. So actually reducing the dose initially and trying to get more cycles in. And so this compared the modified dosing to the standard dosing protocol. And it turned out that we actually were able to get more cycles in for longer time using this dosing protocol. And there was really no difference in the conversion to resectability. So this was published in the Annals of Surgeonc, presented at SSO last year, and hopefully making its way to other HAI centers to see if this is a viable strategy for them as well. So how do we do this? Well, it takes a team. So you'll see there on the right is our kind of surgical and medical oncology team. But it's really then our physician assistants that are at the bottom there that really make things happen because they're the glue between both worlds and also when patients go home. We were fortunate actually to now hire our own dedicated HAI APP. So that's all that he does is take care of our HAI program. Because you can see here on the West Coast and west of the Mississippi, there's not a lot of programs. So we're trying to serve 80 million people in the 13 states west of Texas with 7 HAI centers. And there's a cluster in Southern California, but as you move north, not very much. So how do we do this? Well, in Oregon, for those of you who are not familiar with the map of Oregon, Portland sits at the northwest corner. The Columbia River is our border with Washington. And then there's a big mountain range called the Cascades. And so where Bend sits, which is in central Oregon, it can be quite a distance, usually about 3 hours or so. And so what we try to do between Bend and Medford sits about 6 hours south of Portland, almost on the border with California, is set up some filling stations. So for patients who can't make it up due to weather or illness or other things, we've actually trained the infusion office suites there to at least be able to fill with heparin to try to buy some time so patients can come to Portland when they can. My previous institution in Seattle had started a program and unfortunately was not able to be maintained, but they still have all the infrastructure. So we also have a filling station in Seattle for those that are driving north or perhaps on the way to Canada. So I just wanted to kind of conclude with a case just to give you a perspective of how we use this and perhaps gather some wisdom from the experts that are in the room. But this is a patient that was sent to me from actually Arizona, 73 years old, standard appendectomy, cholecystectomy, but really no significant past medical history, reasonable liver function tests, liver reserve, but had this CAT scan that'll scroll through. And I'm not going to pick on Paul or any of the surgeons in too much, but clearly kind of a big central tumor pushing on the bifurcation, pushing on the hepatic outflow, a challenge to manage, if you will. I'm just going to scroll back in just a second. I'll give Paul a chance to look. So, we did the standard, referral workup and repeated the labs, got the markers, got a multi-phase CT, wanted to make sure there was not a colon cancer that had spread to the liver. And of course, we have a big bias towards biopsying everybody and actually sending for NGS to try to see if we can get any targets that are actionable. Unfortunately, she did not have an actual mutation for this case. And then you'll see here the more detailed liver protocol CT, where you get a sense of there's maybe some multifocal disease, there's some capsular retraction, and you get a sense of where it's pushing on different structures. This helps me as a surgeon decide, is this an operative candidate? Am I doing a right-sided resection, a left-sided resection? And what the arrows are basically telling me is that this thing is really kind of involving all the major, these arteries and inflow and outflow for that liver. So we did have a multidisciplinary evaluation for her. She was deemed unresectable, so started on standard of care, systemic therapy, and completed 6 months of therapy really without much ado, and had a restaging CT that showed stable disease with, markers that were reasonable. You can see here what that looked like. We'll just go through quickly, but really no change, still unresectable. So maybe I'll look at Michael at this point. Treatment options. Maintenance durvalumab for Topaz 1.
Option.
That's one option, okay. But that would be okay in Canada?
Yeah.
Okay, perfect. Radioembolization, Y90? Okay, that's a very agreeable audience.
Funded in Canada, but
Not funded, okay. Got it. What about external beam radiation?
yeah, I think that's reasonable, especially MD Anderson and what we showed here.
Is it funded?
Yeah,
Okay, good.
free.
All right, and free, even better. And then, of course, we're here for an hepatic artery infusion talk, so I'm going to talk to you about hepatic artery infusion. So I did take her for, I always laparoscope everybody to make sure there's no extrahepatic disease, get a liver biopsy. Sometimes I get another tumor biopsy as well if we don't have enough for tissue. We always take the lymph nodes out. We take the gallbladder out as well. She had hers previously removed and really had a very uneventful recovery, was discharged after day 5. With a normal pump study, and then started her FUDR at post-up day 10. We then did restart the systemic therapy because I think we learned from the colorectal data that pump alone, I don't know if we're ready to do that yet. And then got restaged after 2 months of therapy and really showed a nice partial response. So you'll see here what it looks like. And even I think to the naked eye, you can see that it got smaller. So this is somebody who had 6 months of systemic chemotherapy with really no change. Now we added the pump and we're getting a response. So of course, now comes the difficult question. Is it resectable? What do we do next? Paul?
So I don't think it's resectable with negative margins everywhere. I think we could resect it with a bit of an R1 resection if you thought that would help. But if she's, doing well with your treatment, I think continue on.
Yeah. Any other thoughts, options? Rebecca?
I would probably agree with that. Yeah, I think can't do a complete margin negative resection, and I think transplant would be very challenging to vet.
Yeah, and that's where we are now. So basically, she's done well at the pump, so we're continuing therapy, and hopefully, again, if we continue getting responses, I think any of these other options, are still on the table. So I just want to kind of end by giving the shout out to the consortium. So this is what the current consortium looks like. It is an international group. I do see Sunnybrook on here somewhere. Paul can probably find it. There we go. Bottom left. There we go. And there's centers in Mexico and in Europe as well, including Oslo and Netherlands. And as you can see here, how this rapidly has been adopted now through the years. And of course, this is just a quick slide on the current national trial for colorectal mets. This is what I hope that we can get to for intrahepatic cholangiocarcinoma, which is basically taking standard of care chemotherapy after an induction period and then randomizing to pump or no pump. So we're obviously eager to see the results of this just to show feasibility that we can get this done through the NCTN network. And then my dream, Paul and I were both in the Vail ASCO course in 2011, where I actually designed an adjuvant pump trial. This was just with the backbone of GEM at the time, just to give you a sense of the historical perspective. This trial unfortunately never accrued because we didn't have the patient population. I'm hoping that now with the consortium, we can get this done. So I think in summary, just want to give you a sense that local regional therapy with HAI and systemic therapy is a strategy for localized unresectable intrahepatic cholangiocarcinoma. It could have a role in downstaging. I think that's where we'll probably see the initial, the second benefit after the unresectable setting, and then perhaps in the adjuvant setting in the future. I think it's interesting that in the multifocal or node positive setting, HI may be equivalent to surgery, but this needs to be validated prospectively for obvious reasons, especially in the era of neoadjuvant therapy, because a lot of those studies were done before patients were treated with upfront treatment. And then I do think that it's a complicated multidisciplinary team to get this done, but the acceptance is growing and it's feasible. And then, of course, as we learn more about molecular profiling, is can we then figure out who the patients are that would benefit the most? I'll leave you with just a picture of our division, and thank you very much.
That's great. Thanks so much, Dr. Rocha. We will move on with the next talk, and then we'll have a panel at the end that anybody can ask questions to Dr. Rocha and the rest of the panelists. That was excellent. Great. So next to get that was sort of a global discussion of the best evidence currently for HAI. To get the Canadian context on the lay of the land here, we have Dr. Michael Raphael, who is a GI medical oncologist at the Odette Cancer Center at Sunnybrook Health Sciences Center, one of my partners there. And Dr. Raphael leads the hepatic infusion pump chemotherapy program for colorectal liver metastases. There's been a great partner in advocating for this program and really for all patients. He's also a huge advocate as part of the young patients with colorectal cancer program, another specific area of focus of his. So with that, thanks very much, Michael. Looking forward to your talk.
Hello, everybody. Friday afternoon, 4 o'clock. I'll try not to keep everyone from dinner, but I'm really excited to be here today. Obviously, I'm very passionate about treating. Oh, sorry, I'm a little bit tall. It's the shortest one in my family. So I'm very passionate about treating cholangiocarcinoma, colorectal cancer, and GI malignancies, and I'm also consider myself to be a patient advocate. I saw there was a shout out before to CRAN, and I am the co-chair of the Medical and Scientific Advisory Board for that organization. So I'm really excited to be here today to talk to you a little bit about our hepatic arterial infusion pump program in Canada, which is currently for colorectal cancer, but for which we are actively trying to expand that to cholangiocarcinoma right now. So as you heard Dr. Rocha speak, people have been trying to get chemotherapy to the liver for over 50 years. So dating back to 1950, experiments started. We heard there was excellent biological, anatomic, and pharmacological rationale for giving hepatic arterial infusion therapies. And so this is not a new therapy. This is a therapy that, as we've gotten better with our understanding of the anatomy, the pharmacology, as we've gotten better with our surgical approaches, as we've gotten better with working together to generate evidence, that there's been a lot of resurgence and excitement. And so over that time, we have at least 10 different randomized controlled trials showing us in colorectal cancer that hepatic arterial infusion pump therapies can be associated with some really, really dramatic responses. And so over the years of 1980 to 2006, there was at least 10 different clinical trials which quite definitively showed that when you put chemotherapy directly into the liver where patients need it the most, you were going to get much, much better responses than if you just tried to give them systemic therapy. And it comes with less side effects as well. With hepatic arterial infusion pump therapy, it is unquestionable that we get better responses. And the hope is that with better responses, we'll be able to get more patients to have surgical resection to remove what's left. And that's illustrated here in this forest plot. And in more recent years, as you heard Dr. Rocha said, all modern day pump programs now combine hepatic arterial infusion pump therapies, where we put FUDR directly into the liver, with systemic therapy. And this is from the review that Paul and I wrote for JCO a few years ago. And just to provide you some sort of comparisons. Now, these are obviously cross-trial comparisons, but when we look at patients treated in the first-line setting with colorectal cancer, the bars in the gray are those patients who are treated with pump therapies, and you compare that to some of the major randomized clinical trials shown in the white bars below. And we can see that the median overall survivals that we're achieving for our patients are significantly greater in the modern day era, when we give the best available systemic therapy we have with intrahepatic FUDR. And as you've heard today, advocacy plays an essential role in advancing care forward. Doctors, medical oncologists, surgeons, we are a very, very small piece of the puzzle, but patient advocates are what really get things moving, and I truly believe that, and that's why I work so much with patient advocacy groups. So back when I was basically still in diapers, you can see that Dr. Paul Karanicolas is here with two very important patient advocates in Canada, Barry Stein from Colorectal Cancer Canada and Philomena from the CRAN organization. And there was this consensus meeting where it was recognized that we have this amazing therapy just south of the border that our Canadian patients deserve access to. And so there was this consensus meeting inviting experts from around the world involving patients, patient advocates, oncologists, and surgeons. And they put together this guideline or consensus statement rather, about the use of hepatic arterial infusion pump therapy for colorectal cancer metastases. Just trying to make the point that this is an important therapy. This is a therapy that our patients deserve to have here in Canada. And we can have a whole talk about the issues with the regulatory aspects and about the advocacy that Dr. Karanicolas and his team had to put in at the time. But through a lot of determination and time and effort and collaboration, they were able to bring a pump program to Canada at Sunnybrook, which has been operating for almost the past 10 years now. So the pump program first opened in July 2013, and it hasn't been an easy go. Basically, once per year, we have a crisis or emergency where we have difficulties getting access to the drug, difficulties with getting access to the pumps, difficulties with getting regulatory approval, needing to amend our clinical trials because we're accruing so well. We need to add spots for more patients. And so originally, the drug, which is not Health Canada approved, FUTR, was being brought into Canada through the Special Access Program. And eventually, it was converted into being a clinical trial, which we operated originally just to bring the drug to Canada. But now, as we're trying to expand the academic and research mission of the program, we're really trying to build out what we're offering to our patients. And so as of March 2025, we treated 120 patients. And so we actually at the Odette Cancer Center have established ourselves as one of the world leaders in HAI therapies. So our criteria are very similar to what Dr. Rocha showed you for colorectal cancer. And we're just submitting an amendment to our clinical trial because what we're trying to do is loosen up and get rid of all of the excess. We want as many patients as possible to get onto this therapy. So we've tried to eliminate any exclusion criteria that would talk about tiny indeterminate lung lesions. We're trying to include patients now who can have extrahepatic disease that can be curatively treated. We're trying to remove arbitrary blood values. We want to try and make this trial as pragmatic as possible to enroll as many patients as possible to give them access to what we believe is a life-saving therapy. So to give you an idea of the volumes we see at Sunnybrook, we receive about 60 to 70 referrals per year. Over the last year or two, as this has become a more hot topic, people are learning more about therapies, hepatic therapies. We are getting way more referrals than this. Unfortunately, some patients are ineligible for various reasons documented here. So we do about 30 to 40 HAIP consults per year, and we put in 15 to 20 pumps per year. And so here are some preliminary data that we just pulled together for this conference. So from 117 patients who had the pump inserted and had started FUDR therapy, on average, we treat our patients with about 8 cycles of therapy, which is about 6 months of therapy before something happens. And that something hopefully is a good something. They've had a complete response to therapy, they're able to get to surgery. But unfortunately, it can also be a bad something where the cancer has grown and we have to start thinking about the next lines of therapy for our patients. So you can see that we're getting quite impressive results. 73% of our patients will have a response or stable disease. Almost 20% of our patients, 1 in 5, are getting to liver resection. And these are really, truly, truly unresectable patients at the beginning. And 4% of our patients, or 5 in total, have gone on to have hepatic transplants with our partner, Dr. Sapososhan, with whom we have a really wonderful working relationship. And so you saw a similar slide from Dr. Rocha, and this is meant to be busy for a reason. And then just to highlight that starting a pump program requires a huge multidisciplinary team. It requires buy-in from our community partners, from our patients, from our patient advocacy groups, from the hospital, because as I'll show you, there's quite a lot of nuance and funding that goes into this. So I'll just, in the last couple of minutes, because I really want to save some time for the interesting discussion and questions to come, to talk about some of the challenges in building our pump program for colon cancer, because these are the same sorts of challenges we're going to have to face when we build this program for cholangiocarcinoma. The first challenge is the funding, and people who know me know I'm an open book, and I don't know if I'm allowed to share this data, but I'll share it anyways. It's very expensive to treat pump therapy. There's cost to the pump, there's cost to the drug. We have an amazing nurse practitioner who sees all of these patients, and the human resources costs are high. So right now, to treat about 20 patients per year, it costs us over $1 million. So it's quite an expensive program, but as someone said before, we're not really, as physicians particularly, so worried about the money. We're worried about our patients, and so we'll fight to get them whatever they need at whatever the cost is. But of course, if we can bring down the cost so we can treat more patients, that's wonderful as well. Challenge number 2 is supply chain interruptions. Now, this has been helped out a lot with our great friends at Intera Oncology, because they've really streamlined the process, because they've really brought everything under one roof with the drug, the pump, the glycerol. But in the past, we have faced, as I mentioned, about 1 emergency per year. The Codman pump, which you heard from Dr. Rocha, it was suddenly discontinued with no warning, and centers were left scrambling to figure out what they're going to do to treat their patients. Fluoxetine is a drug that is made by only one company. Now it's thankfully made by Intera and their colleagues. And we run into issues with supply, with the base products from time to time. And this is really the only evidence-based drug that we should be using because of the properties you heard before. Challenge number 3 is the regulatory hurdles. We've heard about that in several sessions today. FUDR, despite being a drug that's over 50 years old, has no Health Canada approval. That really limits our ability to expand this therapy across Canada. It limits our ability to do some of those innovative strategies you heard about with sort of a hub and spoke model. Because in order to provide this therapy, you either need to have special access approval or you need to bring it in on a clinical trial. But we're working with our Health Canada colleagues who, I agree with the comments before, have been really helpful in trying to advance this forward. And we're working with Intera Oncology, who have been amazing partners as well, to bring FUDR to market in Canada, because I think there's a need and our patients deserve access to this therapy. So in conclusion, starting up a HAIP program is challenging. It requires buy-in from funders, referrers, and the multidisciplinary team at your center. There's supply chain issues that are a concern, but despite the challenges, the HAIP program is a source of so much hope for our patients and our family. And we heard today about the importance of hope. And it is one of the most rewarding elements of my practice. And I'll leave you with this picture here, because this is something that hangs on my wall. This is something that inspires me every day. This is one of the pump patients that Paul and I treated. I met her when she was in her 3rd trimester of pregnancy with a diagnosis of metastatic colorectal cancer to the liver. Obviously, a very scary and devastating diagnosis. She met with me and Paul, and we were able to get her onto the pump therapy program. She was able to have a dramatic response to therapy with almost complete resolution of every lesion within her liver. And she sent me this wonderful picture that was drawn by her daughter, who I first met in utero when she was inside her mom's tummy at the age of 20 months. And so these are the kind of outcomes that drive us forward. These are the kind of outcomes that make me want to fight to bring FUDR to Canada and to expand the HAIP program to those patients with cholangiocarcinoma. And with that, I'll say thank you.
Okay, thanks so much, Michael. So maybe we'll ask the four panelists now to come up to here if you could. And while they're doing so, I'll just introduce our other two panelists. So now, four of you, please come on up here. So in addition to Dr. Rocha and Raphael, we're delighted to welcome Dr. Katherine Soltys. Dr. Soltys is the Director of the Office of Clinical Trials with Health Canada. And so in that role, Dr. Soltys oversees the approval and pharmacovigilance of clinical trials in Canada, as well as Health Canada's Special Access Program. She's also a GPO in medical oncology, working in the GI clinic in Ottawa, and participates in the care of patients with a variety of GI cancers, including cholangiocarcinoma. So thanks so much for joining us, Dr. Soltys. And at the end, we are equally delighted to welcome a patient partner, Mr. Erik Bradstock. So Erik is a devoted husband and father of two wonderful children. Erik was diagnosed about a year ago with stage 4 colon cancer with liver metastases. He's been treated with hepatic artery infusion pump chemotherapy for that and is now preparing for liver resection. So we really appreciate Erik joining us to share his experience with HAI treatment. So maybe I'll just start with a couple of questions, and then we'll open it up to the floor for anything else. I might start with Dr. Soltys. You've heard sort of some of the background about this treatment. You may have actually come across this treatment through your current office. I wonder if you could just provide a little context from the Health Canada perspective about the regulatory process and how you see this drug FUDR fitting in, and what the pathway to approval might be.
Sure. Do you have a microphone?
Should have a microphone. Sure.
Or I could.
Or do you want to come in? Yeah, you can.
Sure. Should be two though.
Go ahead.
Yeah. Okay. Thank you, Paul. So yeah, in Canada, so we have the food and drug regulations, and I don't want to sound overly bureaucratic, but we have regulations in place for safety and for reasons. When we look at related to drugs, specifically for market access, we're looking at Division 8, which would mean that, so basically to get access to a drug company would need to bring in a drug submission to Health Canada, and they have to show evidence of safety, efficacy, and quality, so chemistry and manufacturing. And so once that has been demonstrated, then Health Canada would issue a notice of compliance with Division 8 regulations, and then the drug is available for market authorization, and then it kind of goes down the next steps in terms of funding. So then the other regulations would be Division 5, which is for clinical trials, and so that's something that my group looks at. So we're looking at basically when a clinical trial application comes in, is the drug safe? Is the drug in the best interest of the participant who's going to take the drug? And is the trial likely to meet its objectives? And so if we think, after looking at the clinical trial protocol, the informed consent form, investigator's brochure, chemistry and manufacturing, if we think that that is the case, then we issue what's called a no objection letter, which then goes to the sponsor of the trial, and then, research ethics board happens and the trial gets up and running, and there's a lot of downstream effects after that. So for FUDR, yes, there is a clinical trial in Canada for colorectal cancer. And, if we wanted to look at it in terms of different disease sites, specifically cholangiocarcinoma, it would be putting together another clinical trial application, as has been done with the colorectal cancer. And that's very doable. And, when this comes to Health Canada, we do the review. We have a 30-day review default time. So it happens very quickly. And so if there's questions, we would reach out to the sponsor to clarify. So that's for a clinical trial situation. Now, to get FUDR on the market in Canada, it would be a drug company coming in with the safety, efficacy, and quality information. And, for drugs that have been used in other jurisdictions, there is what we call it's a submission relying on third-party data. So it's a special submission where you don't have to do original research. You can come in with literature, information from the literature, different marketing experience from other countries. And that can be the basis of the new drug submission. And Health Canada is very happy to meet with a manufacturer if they're with a sponsor, if they have that type of a submission. We can even actually meet them before they start doing a literature review. So I think in terms of FUDR, there is hope, either in a clinical trial setting for cholangiocarcinoma or coming to the market. Okay, thanks.
Okay, great. Thank you. Well, maybe one more question.
That changes real quick, right? So one thing I will say is the teams, the nurse practitioners, Dr. Karanicolas, the surgeon, the blood lab, everyone involved, it's been phenomenal. It really has. It's exceeded any expectation I could have imagined. I probably spent I'm 45 now, in 44 years, 10 days in the hospital, and I've probably spent 50 or more in the last year, right? So everybody from the volunteers to the surgeons to the head oncologists, it really has been an incredible experience. I can't say enough about it. Shout out to Christina Kim, phenomenal. She is the glue to your program at Sunnybrook, a remarkable woman. So, and my team in Oshawa, my systemic oncologist has been there the whole way. You guys communicate really well. They work as a team together. So I can't say enough good words about it. It really has been a positive experience. I've got this far. I've kept working. I've kept living my life as normal as you can. You have your ups and your downs, your time that you have to rest. But I've tried to maintain pretty much a completely normal lifestyle from the day of diagnosis. And now we sit here in front of you guys. And hopefully this program evolves into across Canada. I know it's an Ontario-based program, right? We're hoping this on one of the trialists that kicks us on to the next stage.
Amazing. Great. Thanks so much, Erik, for those words. We'll open it up now for any questions or comments.
I have a question. As a patient, we want those home run options. So how far away are we from putting something else in the pump, like immunotherapy, targeted therapy, or even TIL?
Yeah, that's a great question. I think the pump is a delivery vehicle, right? And so the reason, the advantage that we talked about is the fact that it goes straight to the artery, goes straight to the tumor, but there's nothing magical about what you can put into it. I think the question is, can we do the right studies And I do think in the future, so we're going to start, we have a trial to put oxaliplatin in, but we don't know if immunotherapy delivered via the hepatic artery will have a more beneficial effect. One of my colleagues, Robert Isle, is actually a surgeon scientist who trained, at the NCI and does both immunotherapy as well as CAR-Ts. And so he's really into looking at CAR-Ts for solid tumors as well. So I think the future is bright.
Please, Jennifer.
Erik, you look really well, and congratulations on your CT. What did it feel like? How sick were you?
Not at all. No symptoms till you have symptoms. That's kind of the story I tell people.
Could you feel the pump?
What the pump? Oh, you've done after the install.
Yeah.
Your typical 6 to 8 weeks. Sure, you can feel the pump, but no, is it uncomfortable? I would say no. Maybe when you first bend over, it's the incision. Once that heals up,
What about during chemo?
What about like you're still getting systemic with the
My symptoms from the HAIP pump, very minimal. I always tell people I feel like I'm thirsty. I crave cold things. But overall, symptoms are very, very minimal compared to systemic. Systemic knocked me out for 3 days every 2 weeks on the systemic, and the HAIP's 14 days on, 14 days off while you're going through the cycles, right? So it's 1% of systemic, put it that way. Very manageable. If I wasn't on systemic, which I am, I would suggest they're very, very minimal side effects. Yeah.
Yes. Katherine, can I ask you, this is an old drug, right? And so what happens if there isn't really a sponsor, or it's generic, or I don't know, or it's made through Apotex or something? Like who would take it forward, and how would we get access to old drugs with new uses?
Yeah, so through a clinical trial, that's one option. But if you're talking about market access, I think you really do need a drug company, because there's the chemistry and manufacturing, so the quality side that needs to be looked at in terms of follow-up, recording of adverse events, that kind of thing. You need a drug company for that. So, but again, the data, I talked about submissions related to relying on third-party data. That is a flexibility, because typically for a new drug to get on the market in Canada, you need phase 3 studies. It's a lot more. So, but to answer your question, a drug company, yeah.
Yeah, I think it is a bit of a void in our system. Like that's what we struggled with 10 years ago when we were starting this program. We thought the special access program might help, and we used it for 2 or 3, and then we were told that's not the right route for this. So I think it is, there's not many drugs, I guess, that fall into this category, which is good. But for drugs that have become generic and don't have a leading drug company to bring them to market, it is very challenging. That's why we've had our trial open now for over 10 years, right? When we'd like to be offering this more as standard of care. So I think we may have a path forward now. The drug has been bought by a company in Terra that may have some interest in bringing it to market. And that comes with an increased cost of the drug as well, now that there's only one manufacturer for it. But I think it's a bit of a void in our regulatory system, and I think we should try to address it somehow, More questions or comments?
Online questions. The NIH installs HAIP for extrahepatic CCA. Why do most presentations for HAIP in other hospitals only show that it's for ICC? Okay.
Yeah, that's a great question. Yeah, so the reason is it's the primary sort of liver tumor. It's a mass-forming lesion in the liver. The hilar cholangiocarcinomas are a whole, this is why, we in the community always hate lumping things together, because it really is a different disease. Hilar cholangiocarcinoma is a string disease. It causes, a biliary obstruction, which, as you can imagine, is one of the side effects of the HAI therapy. So we really do not use it for that indication. That's probably the main reason why. I don't know if Paul wants to add on that. There's really not been any data that I know of.
Yeah, no, I agree. Unless you have a very effective systemic drug that's going to work on the disease outside the liver, there's not a lot of rationale for treating the liver so intensely when it's spread beyond that, I think. So
it's also the dual supply of the liver that you're taking advantage of. When it's at the high limit outside, it's perhaps not as effective, right?
Right, exactly. Yeah. So for an extrahepatic, for bile duct cancers, there isn't going to be the same concentration of drug going there.
Another question was, it was mentioned that the pump therapy could be used for adjuvant therapy. How would this work? Would it require remaining active disease?
Yeah, that's a great question. So adjuvant therapy is treatment once the disease is gone. Because patients always ask me when I take out their cancer, they're like, well, why do I need more chemo? And I said, remember, all I can take out is what I can see and feel. So the microscopic cells I can't take out. And so that's the reason for the adjuvant therapy. So as I mentioned in the talk, 50% of patients will recur at 2 years, despite what I think is the best operation they had. So that tells me that there's some disease that's floating around. And so the idea behind the adjuvant therapy is that we continue the treatment to clear out that what we call micrometastatic disease. And we know that chemotherapy has different effects, whether it's micrometastatic or macrometastatic, meaning a solid lump of tumor. So, in most diseases, you'll see in the GI tract, we give adjuvant therapy. Think about pancreas cancer, think about colon cancer. And so there is a rationale for this in this disease. It's just that it adds another layer of complexity, right? Because now you're doing a big liver resection, then putting in a pump at the same time, and then you're delivering that chemotherapy when that liver is, presumably still recovering. And so that's the challenge in doing adjuvant therapy. So we really want to establish this in the unresectable setting first, and then be able to then take it on to the next steps. But that's another trial I would love to do, is compare it to the current standard of care, which is gemcitabine.
I have a question for Dr. Rocha as well, if I could. The case you showed, you treated that patient for 6 months, I think, with systemic therapy before putting the pump in place. Can you comment on how much systemic treatment you think is optimal before putting the pump in? I mean, I think in the colorectal setting, we try to put the pump in much earlier than that. We find the earlier you put it in, the more the response is. Is it similar in biliary tract?
Yeah, the short answer is we don't know. Right. So I think all of us, at least at our institution, we feel that we want to get some sort of induction systemic therapy first to really make sure that there's no extrahepatic disease. That case, they actually started their systemic therapy in Arizona. And so we kind of got the patient sort of mid-course. And at that point, we said, look, you're tolerating systemic therapy. It's at least stable disease. Let's just kind of finish out the prescribed, standard of care as we're entertaining something that's not quite standard. But that's part of what the Helix 2 trial was going to try to answer as well. Is what's the induction? What's a proper induction therapy duration?
Great. Okay. Well, if there's no other questions, I might just give a brief update on just to let folks know we are planning on joining the trial that Dr. Rocha showed that's being run out of Sloan Kettering, the randomized trial comparing systemic therapy to HAI plus systemic therapy in cholangiocarcinoma. So we are looking to join that trial, and they would like to have us part of it. So they've shared their protocol with us. So we are hoping that, I'll say maybe by the end of this year, we hope to have that trial open, which would be a nice option to have for patients in Canada. We have some regulatory and other challenges to get through, but we're optimistic that we'll be able to do that. So with that, we'll thank all the panelists again very much for contributing to this session.